podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we talk to international experts who share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical situations. I'm your host, Dr. Dana Hartl. I'm an otolaryngologist and head and neck surgeon at the Gustave Roussy Cancer Center in France. And it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. I will be hosting the second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all her hard work on making these podcasts a reality, and congratulate Janice and all of those who've contributed to the success that these podcasts have become. We created this podcast to provide clinicians with short, easy-to-digest highlights of clinical issues that we all face while treating cancer patients. Our aim is to share evidence-based information as well as practice-based experience and tips from world-renowned experts. In each episode, I am joined by distinguished international guests who bring their unique perspective and expertise to the discussion. So whether you're a surgeon, an endocrinologist, pathologist, medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, we're joined by Dr. J.P. Brito from the Mayo Clinic for a practical conversation about thyroid hormone replacement therapy. From optimizing TSH levels in cancer patients to navigating persistent symptoms and combination therapy, Dr. Brito shares thoughtful insights and clinical pearls that every thyroid clinician will find valuable. We're excited to welcome Dr. J.P. Brito to the podcast. Dr. Brito is a professor of medicine, endocrinologist, and a healthcare delivery researcher at the Mayo Clinic. He has served as co-director of late-stage translational research in the Center for Clinical and Translational Science and is the medical director of the Shared Decision-Making National Resource Center. A prolific researcher and active member of several national guideline committees, including the American Thyroid Association's panel for guidelines on the current management of hypothyroidism. Dr. Brito's work focuses on thyroid hormone use, treatment trends in Graves' disease, and minimizing overtreatment in thyroid cancer care. So let's get started. Hello, JP. Thank you so much for joining the podcast today. It is just really a pleasure to have you with us. So I'm going to jump right in. The idea is to talk about thyroid hormone replacement therapy today, sort of how you do it and how you manage patients that can have some complicated issues. First of all, do you have a rule of thumb for optimizing thyroid hormone replacement when you have a patient who, for example, has just had surgery?
Yes, absolutely. And Dana, thank you very much for having me here. It's really a pleasure. For most people with hypothyroidism, the primary goals are to resolve symptoms, normalize thyroid levels, particularly thyrotropin, what you probably want to call here TSH, and avoid overtreatment. But yes, when it comes to thyroid cancer, particularly with patients at higher risk of recurrence, we tend to change our goals to shift towards suppressing thyrotropin or TSH. Why is that? Because by suppressing TSH, we know that the risk of recurrence actually does decrease. So the rule of thumb that is being suggested by guidelines is if you have a patient with very low risk of recurrence, you might want to have a TSH between 0.1 and 0.5. If you have a higher risk of a patient with higher risk of recurrence, you tend to aim to a little more suppression, maybe to keeping the TSH below 0.1. But the key aspect here is that I think we should consider a lot of individualization in that TSH management. Why is that? Because while TSH suppression, that shows some benefit of decreasing the risk of recurrence, maybe the literature is about 15 to 30% risk reduction. We know that it's not a guarantee of protection. And while suppressing certainly can help, particularly patients with high risk, is really far from a cure-all kind of approach. So why I'm saying this is that suppression therapy isn't a benign thing. Elderly, frail patients, or even those with cardiovascular conditions, we know that suppressing the thyroid hormone TSH. TSH does bring the risk of arrhythmias. Patients might have symptoms, they described palpitations, chest pain, shortness of breath, tremors. We know that by suppressing, we do increase the risk of osteoporosis and bone loss, and new evidence is coming in regards to even cognitive decline when we suppress patients for a long time. So, as clinicians, perhaps the most important message here is that we have to balance the risk against the potential benefits when we're suppressing TSH. I don't think we can adopt the one size fits all mentality here. Not every patient with high risk disease needs to have their TSH completely suppressed. I think we need to tailor this recommendation very carefully based on the context of the patients, the comorbidities, and mostly on the symptoms. And I'm saying this because many times I see patients that they are being told that this is part of the treatment, the oncologic treatment for thyroid cancer, and you can see them very symptomatic, very fragile, and they need to do it. They think that they have to do it because otherwise they will have cancer coming back. And we know it's not like this. If there is benefit, we try to do it, but certainly it has to be individualized based on patients' context values, even preferences. So I think that's the most important message, the individualization of this for each patient that we have in front of us.
And that goes along also with ongoing risk stratification too, to say that a patient who's low risk but has an excellent response, are you going to lift some of that suppression? Would you consider doing that, or is that?
Yeah, no, that's exactly the point. So I think the guidelines are going in that direction. If we go back to the guidelines many years ago, suppression was for everyone, and as the guidelines get better and the evidence behind those recommendations get better, we know now that if you have a patient with very low risk or low risk of recurrence, which probably even up to less than 10% in the next 5 to 10 years, the benefit of suppressing these patients is really, really minimum. And it goes with the idea that the higher the risk, the more the benefit. So the lower the risk, meaning lower than 10, the benefit is really small. And follow with the same principle is that these patients having a very low risk disease are very unlikely to suffer from the condition. And you don't want to put additional burden on them of suppressing TSH when we know that the disease is not as bad. So this goes with the idea of normalization of life, going back to what they enjoy and trying to avoid, having the idea that they need treatment forever and and suppression forever.
Well, that's great. So we really have to be in tune with their quality of life. I think we've all had patients who don't feel normal anymore after thyroid surgery. They don't feel normal on the thyroid hormone replacement. I'm losing my hair. I've gained 10 pounds. My family says I'm irritable. Things like that. How do you go about sort of weeding out what could be related to the thyroid hormone problem, or a problem with the thyroid hormone rather, or other health issues?
Yeah, this is I would say, a very important topic. One that I think many clinicians and patients grapple with. Those lingering symptoms after thyroid surgery, for instance, even when the TSH is in normal range. I think we, as clinicians, we see these patients very often, and patients also are facing with these problems. So I think it's important to recognize that perhaps we have two different patients here, patient profiles, or even if we call it phenotypes of patients. So first, there are the patients who already had these non-specific symptoms, namely fatigue, weight changes, joint pain, sleep problems, long before the thyroidectomy. So these patients might experience worsening of symptoms after surgery, but it's not necessarily due to the surgery or to the levothyroxine therapy. I think it's in the context of a cancer diagnosis, stress, frequent appointments. I think all those factors really amplify the existing symptoms. So critical here is not to rush into saying that the thyroid replacement alone is the reason why the symptoms might persist or might have exacerbated a little bit. So in these cases, the first kind of group of patients, I do encourage broader evaluation. So what I mean is dealing with these issues of maybe there is another underlying problem here: iron deficiency, chronic pain syndrome, sleep apnea, mood disorders. They are really frequently overlooked. One of the things I think is overlooked quite frequently is premenopause. We know that premenopause comes with many symptoms that we usually allocate to hypothyroidism, and it tends to happen even years before the actual definition of menopause. So I have many patients that come with that kind of constellation of symptoms. When we go through the evaluation, actually, it's obvious that patients undergoing premenopause. So for these patients, a more comprehensive multidisciplinary approach is needed. No, having a good primary care doctor that can help us. Even we are fortunate in some of the clinics that we work. We have the fatigue clinic, pain clinic, and if we're lucky, we get mental health support as well. So the other piece here that lessons learned after many years of practice is that you might want to tell these patients before having surgery about what happens with the symptoms. So you can tell when these patients are already struggling. And you might want to give them some degree of expectations that you have seen because of the significant amount of stress, which is being diagnosed of cancer, that is expected that some of the things get worse. And you will also expect that that is not because the cancer, so the cancer is unlikely to cause the symptoms, and it's unlikely that the thyroid hormone will lead to a worsening of the symptoms. That expectation, the management of expectation really helps because in the mind of the patients, I think they connect symptoms with cancer and they connect symptoms with as a side effect of treatment. So I think it's important to recognize in these particular patients by having good conversation before surgery that things can happen, things can get a little bit worse before they get better sometimes with the symptoms. So that is one group of patients, which is a good number. The other one is a little bit trickier because these are patients who feel great before surgery. They are active, energetic, living their lives to the fullest. And they have the thyroid removed, particularly when they have the whole thyroid removed, I would say. They start levothyroxine, and suddenly they come to the first visits and they say, I'm not feeling yet back where I was before. And you give it some time, months pass by, and they continue to tell you that, and sometimes you can see the symptoms getting worse. Uh, you check the thyroid levels, and they are within normal limits. So something is off. Something happened at the moment of surgery that changed the biology of the patients in a way that we don't yet fully understand, to be honest. So we actually explore here a very simple review of the cases at Mayo Clinic, and we noticed that patients, in about 20% of the times when we do have the follow-up to assess this, patients who did not feel bad, that they actually were feeling well, they had surgery, about 2 out of 10, they did develop symptoms of what we might call unexplained symptoms in the follow-up. So it might affect quite a bit of our patients. Now, if we were to follow these patients for a long time, I can see that many of those patients start getting better without doing anything. I always tell my patients, it seems that it's just an adjustment period. But some of the patients do have these persistent symptoms beyond that. So, what to do with them? So, two things that I think the research is getting to the point that might, to some extent, explain this is that when we think about normalization of TSH, we sometimes think that TSH is the best biomarker that exists. And it's because traditionally, since 1970, it has been the best biomarker that exists. But we know now that it's not the perfect biomarker. TSH is a good biomarker of normal or a good replacement in regards of the feedback loop, meaning the TSH that we have is the TSH that comes from the pituitary gland after the levothyroxine has turned into T3 in the hypothalamus and then the pituitary gland. So by definition, is a reflection of concentrations of T3 levels in the regulatory tissues. Does that mean that patient has enough T3 in other tissues and other parts of the brain? So some evidence suggests that might not always be the case. So the TSH might be normal, but there might be some T3 deficiency in other tissues. And it is possible, yet of course not fully explained, but it is possible that these patients do have some degree of T3 deficiency that we have not been able to compensate yet. And the other thing that which we see with the other endocrine problems is that when we think about what is normal, because I just say normal TSH, normality is a very interesting thing. Normality in TSH is what is normal for the 95% of people like you. So in thousands of patients, we have a nice curve of what is normal in TSH value, and we just arbitrarily say the majority of people fall within this range, which might be usually between zero point 0.3 and 4.2 for TSH. But it does not really mean that that is normal for you. So there have been very interesting studies, many of those quite old, that they just measure TSH in patients and same patients every day for many years, no, so for many months, not years. And they have noticed that people tend to have a very narrow normality of TSH. The younger you are, you tend to have more, perhaps between 1 and 2. The older we become, it might shift to 2 or 3 or so. So if you see a patient that is feeling well, you have a TSH, maybe a couple of them before surgery, and you notice the TSH is between 1.2, 1.5, and suddenly after surgery, you have a patient with TSH of 3.5, although it's normal, I always wonder whether that is normal for her or for him. So those kind of things that I believe start creating a story here that these patients that might have persistent or new symptoms after thyroidectomy, we might be failing to understand what exactly is going on, and perhaps these two clues might help us design treatment.
Well, that's terrific advice too, to listen to the patients, try to get to know how they are before surgery, and then listen really to what they're saying, because it's very hard to make the difference between, as you say, the different periods of life too, I guess, older, menopause, activity. Um, so do you have like a biomarker or signs or symptoms that would tell you that a patient maybe needs T3 supplementation? Do you do that?
And again, this is where we're getting into muddy areas because we there is no such thing as a good biomarker that give us the whether we are lacking T3. The T3 measurement that we get in the blood is really the blood T3 that we are measuring, but we know that that is just a small fraction of actual T3 concentration in the cells, which is the part in which the T3 really has a role. So it's a surrogate, I would say, but it's not the best surrogate. And there are many groups that are working on developing better surrogates of this, but I think it might take a few years to get to that point. I think the most important thing is that when we are facing these patients, the ones that have new symptoms after surgery, that we really think there is something real here related to the thyroid, I think we first have to listen. So listening is very important. The majority of these patients get neglected because the TSH is normal and they are told that this is something else, when clearly the thyroid removal did something. And they suffer, I would say, equally to the symptoms to the lack of care. Uh, so the first thing is, to acknowledge that the symptoms are real, to acknowledge the suffering, and also to be quite open to say things like, we don't always know why this happens. We don't fully understand why this happens. And then that opens the opportunity to try things that might not yet be clear evidence for or against, but opens the room to, I want to walk with you this difficult path. Let's see what we can achieve. And so it's not really a measurement here problem. It's not like if the T3 is low, I will certainly jump to give T3 treatment. I think is expected in patients that have low T3 in the blood. I don't rely on those. I rely on mostly this conversation, because when I have this conversation, it's not really about lifting the T3 than the goal. Is really trying to make you feel better, trying a few things together. So, and that leads us to, okay, so what? So what can we try with this patient? So the first thing that we try, at least in my practice, and I think we are trying to develop these algorithms in practice ourselves, is I do trying to lower the TSH value to something that is more in reflecting perhaps the age of the patient or understanding what was before surgery. The trials that have been done in different TSH ranges have been done in patients who don't always feel symptomatic. And of course, they don't have improvement because the baseline was not always bad, but there had not been any clear study in which patients did not feel well and they went back to the TSH before surgery, which I think that's the trial we need. And I, because of the lack of evidence and because it's relatively safe, I do try to mimic what most likely is a better range for that patient. And I do try it for a period of 3 to 6 months and reevaluate. That's one of the first things. Many patients actually feel some improvement. Many they don't feel anything at all, and then we say, okay, maybe we want to try something else, and that something else sometimes is adding T3 therapy to the T4 therapy. Why T3 again is because that's the active hormone. When we get the thyroid out, the idea is that we are missing a little bit of that production from the thyroid. Not every T3 is being produced at the tissue level, so we're missing something comes from the thyroid. And again, it might be that these patients have some degree of T3 deficiency.
So is there a future? We hear about polymorphisms with deiodinases, peripheral deiodinases that convert the T4 to T3, and that might be variable in different peripheral tissue. And like you said, would maybe explain why some people have lower T3 levels in their brain post-operatively under therapy. Is there a future for patients who don't feel well, like looking at their polymorphisms or dosing? Doing something in the peripheral tissue to get better, see what maybe T3 needs some people might have?
I think that's one of the areas of active research is trying to find whether we can distinguish and diagnose these patients that might be a high risk of persistent or new symptoms. I would say that the polymorphism, the ones that are frequently described, have not been the ones that come back as very sensitive or specific tools for us to distinguish this. It seems that they might have some role mostly in the brain in non-regulatory areas. Some studies suggest that perhaps that might be something in which those patients might have some low T3, the brain tissue, but it has not been the tool that come up to the practice and said, let's measure polymorphisms, because if we have a positive polymorphism, maybe we're going to be very conservative with you. Maybe we're going to do lobectomy as opposed to total thyroidectomy for you to have some residual thyroid function. So no, it has not become as a useful tool in practice. I think it's important to keep moving that in research because maybe there may be other changes either in the omic ecosystem or proteinomics, other signatures. Maybe even the use of artificial intelligence to trying to come up with signatures in patients in whom we might be dealing with this in the future. I think is probably the next steps. It might take us a while, but one of the issues that I can see as a difficulty there is that it might be that patients, we don't have a kind of a good, what is called gold standard in regards to where a deficiency actually is a problem. So I'm always amazed sometimes by patients that have clearly hypothyroidism and they have no symptom whatsoever. So clearly, if we measure something on those patients, we will find deficiency, but that deficiency is not getting translated to a bad quality of life. Patients sometimes are marathon runners, they do extremely well. You have these patients with TSH of 11, they don't want to receive levothyroxine, and they do spectacular. So I think is for us to explore that in order to advance this field, we also need to get the symptoms, better assessment of them, better assessment of the change over time. So I think it's going the aspect of research at this point, not really in practice. We don't have yet any of those tools.
Okay, so that's fascinating. That is amazing. It's true. We have patients that say, "I don't want thyroid hormone," and they're like, they're like, "Oh," you look at their TSH and like, "No, you can't do that." But that's their choice, and they do just fine. So in terms of lobectomy versus total thyroidectomy, there were some studies that showed, better quality of life after lobectomy, even with patients who needed some thyroid hormone supplementation. So here, listening to you is maybe not just all about T3.
That's very interesting because there have been some studies that they have assessed quality of life. Of course, all these studies do have a little bit of selection bias, but they have consistently shown that patients in whom you have the whole thyroid treated, I'm mentioning treated because I'm bringing the patients with Graves' disease, for instance, that they do have also, as a part of the treatment, the possibility of having thyroidectomies. The quality of life seems to be associated with the extent of surgery. And Graves' disease, of course, is whole thyroid is removed, and the quality of life is relatively low. And also patients with total thyroidectomy compared to lobectomy. I think we're seeing that happening. Whether that is a very combination of things is unclear, but maybe the story behind it is that they also have some thyroid reserves, meaning they still have some endogenous T3 production, or just the fact that for those patients, TSH is actually a better biomarker. Because remember, the biomarker problem with TSH in levothyroxine replacement seems to be that the enzyme that turns the levothyroxine to T3 in the brain seems to be very quick to act, as opposed to the enzymes in the periphery. So for more levothyroxine, you will have a normal TSH because the loop works very efficiently, but the loop in the tissues is not as well. So it might be that the TSH is a better marker. We can treat patients better, or it might be that we have enough T3 endogenously, and that's why we don't see the problems of quality of life. Regardless of this, I think the story is that we can be as conservative, we should aim to be as conservative as possible to trying to preserve the quality of life. And yes, sometimes we are eager to have better oncologic outcomes, meaning better thyroglobulins. But at the end of the day, who cares about thyroglobulin when if you have a patient that is suffering? So certainly, I think this is the part that we will sacrifice a little bit of of the oncologic outcomes in regards of excellent thyroglobulin response to trying to preserve as much as we can normal thyroid function, for instance.
That's terrific. That's already a word of wisdom. But do you have other tips to share with us to wrap up this fascinating discussion?
Yes, I would say that this is a practice in which you have what it seems to be an effective treatment so many decades, and we are realizing that maybe we got it wrong for few of these patients. Research hopefully will catch up in regards to better biomarkers, different ways of replacing. I know efforts have been focused now on perhaps getting better T3 replacement regimens as opposed to the one that we have right now. It's not ideal. I would say also that listening to the patient might be the most important thing. Many of these patients might still have symptoms, but when they feel heard, that there is a relationship with the clinician, that the clinician understands, even though it cannot fully explain, but understand you and is willing to try things, I think that's probably the most important step here. And eventually, again, when we have more, perhaps better biomarkers, interventions, we might be able to help them a little bit better.
That's terrific. To care is maybe just as good, or in some cases just as good as to cure.
Absolutely. And I always tell patients come to have the treatment or have treatment to cure. We know we cannot cure cancer, but we know we can care. And that is what matters. We cannot cure chronic conditions. Usually we cannot cure cancer, but our goal is to care. And if we ended up caring, and you can feel when somebody is cared for, I think that is a significant thing we can do. And we don't need always, the best treatment or the perfect treatment to do that. Of course, that's the goal of research. But in the meantime, walk with the patients, help the suffering, help alleviating the suffering, and relationship building is always important.
With those words of wisdom, we're going to wrap up this podcast. Thank you so much, JP, for sharing all of your experience and insight and knowledge and research And so I think it'll be exciting to see what the next years bring in terms of changes in our habits and practices.
Absolutely. And Dana, thank you very much for having me.
Thank you. And that brings us to the end of this episode of Voices of Wisdom. I'm Dr. Dana Hartl, and it's been a pleasure to host today's conversation on thyroid hormone replacement therapy, how to optimize it, when to consider combination treatment, and how to support patients who don't feel well on standard T4. A sincere thank you to Dr. J.P. Brito for joining us and offering such thoughtful guidance from managing TSH targets to addressing persistent symptoms and shared decision-making. Thank you, JP, for helping us better understand this nuanced topic and sharing your clinical experience so generously. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting second season ahead of us, so please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time, US. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. Just visit tyro.expert/subscribe or click on the link in the description. Thank you for tuning in to this episode of TIRO's Voices of Wisdom podcast. We'll see you next time. Until then, take care and keep making a difference.